Welcome to the Clear Triage 10 for 10 educational speaker series. We're excited to have you all here today and excited to have Cecilio Murillo here to join us in the conversation today. Cecilio has spent his career focused on improving access to healthcare. He currently serves as the System Vice President of Ambulatory Access Strategy and Operations for Common Spirit Health, where he's responsible for developing, leading, and implementing enterprise-wide access operations and strategy, including the OneConnect platform that we'll be talking about today. His leadership in this role and his focus on optimizing patient experience and enhancing consumer relationships also led to Cecilio being recognized by Modern Healthcare this year as one of the 40 emerging leaders under 40. So congratulations, Cecilio, and welcome to our webinar series.
Thank you, Dave. Guess I can't lie about my age anymore.
Well, we don't know we know you were less than 40 at least 2 months ago.
True. That's true. No, thank you so much. It's a pleasure to be here with you. Appreciate the time.
Well, great. Well, as I mentioned in the intro, that part of our conversation today really is around OneConnect, and I found it just fascinating as we were talking at conference either a year or two ago about that and what you're doing with that in Common Spirit. And so I'd like to explore that because I think it'll be valuable to our listeners and to a number of people involved in Clear Triage. But I think that before getting started on that, I think it'll help people to understand a little bit about what is Common Spirit, because I think you came into Common Spirit through one of the parts, through Dignity Health. Can you talk a little about Common Spirit, and then we can get into what led to OneConnect?
Sure, happy to. Well, Common Spirit Health really came together as the merger of two large nonprofit Catholic health ministries, Dignity Health and CHI Health. And in 2019, I think we brought together about 1,100 care sites. But even since then, in 2019, we've grown now to over 2,000 care sites,
Wow.
140, I'll say 140 plus hospitals, so I don't get the number wrong. And we are spanning across 24 states today between the Pacific Northwest, California, our central region, the mountain region in the south. We support via all facets of ambulatory care, specialty care, residency programs, our partnership with several university systems, just Creighton, Morehouse School of Medicine, Baylor College of Medicine. And again, the advancements that we've had both in technology and care has just been
Wow.
immense within Common Spirit Health. It's been great.
Well, so you had a huge combination back in 2019, but it sounds like you've almost doubled since then as well. So that's a lot of growth, which I think led to the idea of the OneConnect platform. Can you talk
Yeah.
about kind of what drew you in that direction?
Yeah, I don't think that too many systems have the challenges and opportunities that we had, because as you could see that the merger of several health systems obviously would mean the merger of several different instances of technology, or in our case, the lack of merger of technologies and having disparate systems. So across Common Spirit Health, at one point we had 26 different source systems, practice management systems, electronic health record systems, unfortunately some paper that
Mm.
we are moving toward away from. But even then, I mean, how do you support a ministry and an organization of our scale with so many disparate systems? And how do you ask people to do the work in an efficient and scalable way when the IT team will say, well, you need two different computers to have that, or you're going to have several logins. It's crazy making what we ask our teams to do and yet be successful and efficient. So OneConnect was a solution of ours.
So what is OneConnect and how does it help address that issue?
So OneConnect is great question. OneConnect, as we called it, is the leveraging of Salesforce's Health Cloud CRM, a customer relationship management system that allows us to have sort of an overlay over our EHR platforms. So never serving as our source of truth or source system of information, but really being a direct overlay to create a single pane of glass. I will tell you that, and you wouldn't You may or may not be shocked to hear that our contact center staff, our remote and virtual staff often
Sure.
have 8 to 16 different screens that they have up on their monitor windows on their monitors. You've got the
Mm,
provider preferences, the triage protocols, the insurance verification screens, of course, the scheduling, the EHR, the different patient record systems. It's it's a lot to manage. So when we
sure.
talked about having this single pane of glass, it was how do we bring in all of these different source systems, configure it into one where we really could have our staff working in one single screen, have all of the information brought to them. I think of it not so much from a how do we just simplify, streamline the work, but how do we enhance the work that we have in front of us? You've got the patient in front of you that is calling for a cold today. They're not they're not calling about that colorectal cancer screening. They're not calling about their A1C that's past due or their high blood pressure. They're calling about the cold symptoms. That's why they called. But how great would it be to not have to dig into the chart and have a layperson and a nurse team member be available at any given moment to be able to talk about, hey, I'm seeing, by the way, that you have your last blood pressure reading was elevated. Have you had your blood pressure checked since?
Okay.
And be able to start that conversation. We couldn't, while we could do that in the past, it was very time consuming. It would have to lead to, again, a layperson starting to blur their lines of scope of I'm now digging in a patient's chart to find something that really we could bring to the front. So it's allowed us to do a lot more for our patient care.
I have two interesting tacks, and I'll try and keep them both in mind so that we can cover both of them. But one, you mentioned the 8 to 16 screens that they have up, including insurance verification, a bunch of things that really that are I would imagine aren't in the EHR. So it's not just the situation where they had all of the different EHRs that came to, they had a bunch of other screens. So have you managed to bring all of that together so they really are working in largely one pane of glass, the one window that gives them access to everything?
Yeah, correct. So, you know, depending on the back of house team that you're dealing with, the business office, you know, the revenue cycle team, they'll want to make sure that we're running real-time eligibility on every single patient. But at the same time, not every call requires us to run eligibility. Not every call requires us to check their benefits. But why not ensure that before we schedule an appointment or whatever test we may be offering that the patient should be receiving, why not make it a simple part of their workflow, not a not digging through different systems to find the right approach. It's often where we find that our staff or team members may cut corners or may create their own paths because it's not simple, it's not intuitive. I will say that with OneConnect, we built out a intuitive platform that takes the team member through step by step different cases, whether it's I need to schedule an appointment, I'm looking for results, I'm trying to send a message, I'm trying to get a prescription. Uh, While I share the funny story of, of course, I said on day one, gosh, this looks so easy. And the team member took his headset off and said, do you want to take the next call? I thought, oh my gosh, I don't know. I mean, now I put my foot in my mouth. I have to take the next. And while I sat through the trainings, I didn't participate in all of the trainings as in depth.
Mhm.
We took 120 hours of EHR system training, practice management system training, telephony system training, 120 hours of monotonous work and created a 26-hour training with Salesforce that was intuitive. So when I jumped on, put the headset on, I didn't have to worry about the phone system. I didn't have to worry about logging into different platforms. We created
Hmm.
a single sign-on that logs you into today 5 different EHR systems. With obviously with us having Dignity Health, CHI Health, we have 2 instances of Cerner, 2 instances of Epic and an Athena IDX practice management system that so long as you have those 5 logins, plus your telephony platform, plus your workforce management system. So now we're talking about 7 different systems that with one single sign-on, I'm in. I don't have to think about all those different places.
So the other part I was going to take us down, when I said I had two thoughts, you'd mentioned originally you started with 26 different EMRs and practice management systems. So you have done some consolidation in those. So you have your basically your Epic instances, your Cerner instances, you have Athena there. Um, why? So I guess why that consolidation, but why not the total consolidation down to a singular EHR?
Sure. Common Spirit Health is definitely on that path. We're working to get to one single instance of an EHR that can be supported across our entire organization, but that takes a lot of time. We're talking about a 5-year path for us across Common Spirit, and while that is necessary for our hospitals, for our ambulatory sites, for our imaging centers, that takes a lot of different governance. And again, you're creating the single EHR that has to be supported and work for tens of thousands of providers and other team members within our organization. What we're talking about here is think of it as the administrative health center, the patient connection center, which is what operates within Salesforce today, the OneConnect system. We've taken everything that is administrative that happens in your clinic can be done within the patient connection center. Everything except for physically touching the patient, seeing the patient. So for us, it allows us to be more nimble and being able to create change, modify enhancements, streamline the work without having to touch the source systems. Because while we certainly have a path to 5 years being on one EHR, today we still have the problem of having to work within several instances. When we started this, we literally asked team members to have 3 to 4 different EHRs on their computer screen,
Hmm.
answering for multiple regions between different counties or states across time zones. So the problem we have is now, how do we support all of these regions that are on disparate systems while we get to the ultimate solution? So I think while we
Sure.
have a unique challenge, it's probably not unique to many organizations, regardless of size.
So I think I know the answer for this. So maybe I'm throwing a slow pitch right over the plate for you here. But will there be value in OneConnect once you've consolidated down to one EHR, and what would that be?
Yeah, I think so. I think between now and then, we certainly have a lot of time to enhance the product, enhance the overall software, I suppose is the best way to put it. Thinking of it as what's next? How do we integrate with our marketing teams, with our sales teams, with our population health teams? What information are they looking at that can be brought in so that when I speak to the patient, because again, I'm not calling to remind you that my blood pressure was elevated the last time I came in. I'm calling for the acute issue. How do we take advantage of connecting with that patient the one time that we're going to get them? That
Sure.
what else did we need them to know about, whether it be in their family medical history or the recent lab work that they got and they ignored? We want to be preventative, obviously.
Sure. And I think having listened to you describe this before, it seems like another piece of value you provide is this overlay over scheduling. Um, you've described um, working and negotiating on how to schedule, and that's you have these two different extremes of um, giving every provider absolute individual control over what they're doing versus taking everyone down to a singular, this is how you're going to have your appointments. You've wound up somewhere in the middle. Can you talk about that journey? Because I think that that's something that I'm sure a lot of our listeners are dealing with as far as scheduling across their organization.
Yeah. I'll tell you that when I came to Dignity Health, I loved that the way I always described it was I walked into that private practice feel. So when you walk into a Common Spirit site, you really do feel like you have that private practice feel. The providers still have that level of autonomy to say, I want to see this type of patient in this much time with this parameter. You really do have that, but you have the support of these behemoth health systems to allow us to really be, as we say, physician led, clinician led, operationally enhanced and supported. So it's our job to find the best medium to be able to provide this. So when we sit down, the work in the connection center really is about how do we document all of those provider preferences and then bring them together as physicians and APPs to say, how do you want to see this? What is the best way to create a clinical script that will allow us to get to the right place, the right time with the right level of care for that patient? Um, I wish we would have discovered symptom screen before we went down this path, because obviously we created a lot of this work for ourselves. Not that it was bad; it's amazing work that we've done. However, it's work that takes a lot of maintenance. We make sure that we have to connect with all of our physicians as we have to make changes, rules, workflows, etc. But nonetheless, once you answer the phone, the real operations begin, right? The real work begins after we answer that phone. It really doesn't matter if I can answer a phone in 10 seconds if I don't have the operational foundation to support the patient on the other end.
Sure. Um, well, you brought up, so let's dive into this piece of it. I think anytime that you're driving strategy at a high level in a large organization, anytime you're doing that, and I think wherever someone is setting strategy, you have sort of competing ends to that. There's one point where you can research everything and really decide, okay, spend a lot of time figuring out what you need to do, with the risk of doing too much of that gets you the paralysis by analysis kind of corner. Or the other is you're just going too fast and charging in. And I think that symptom screen, we've talked about it because symptom screen is something that you found after you'd implemented a lot of your
Mhm.
screening preferences and you're using it outside of OneConnect, but it's been difficult to bring into the Salesforce platform. But yet, I don't know that you would have gone back a couple of years and said, could we have taken the time to do that? So how do you balance the figuring out what's there and picking the best solution versus you need to get things done?
It's, I don't know that I have an answer for that one. It's a tough one because you're right. You know, we, I started with the organization 8 years ago. And 8 years ago, my problem was on week one, a patient calling the CEO of Dignity Health asking for their prescription refill. I don't know how that call made it all the way through, but obviously we had a problem of 2 hour wait times, 45-minute wait times on a daily basis. We had to implement things quickly to be able to support the immediate need, while at the same time, we've been talking about a CRM solution since 2017. It was just a matter of, do we have the money to do it? And do we have the funding to do it this year? The first nurse in our connection center was a requisition created out of the loss of two call center agents. We said, well, we won't backfill two agents because we will hire a nurse instead. So it's been a lot of patchwork between now and the then and now, with the idea of, okay, how do we create everything that we do needs to be scalable. So we created provider preferences, standard work that were scalable. And then once we had the funding, we took the next leap of faith. I think with symptom screen, it was a matter of, well, we already went down this path, but we haven't gone down that path for our specialty practices. Our primary care practices are all working within the OneConnect platform. The specialty practices that we support are still living in the native legacy systems, the EHRs. So it's perfect balance for us of let's use both until we meet in the middle somewhere down the road.
Sure. Um, on a related note, so I mean, you have this experience, so you're 6 years into OneConnect now. I'm not sure how much of that is live, but you're,
Two,
you're you've
two
been
years,
live for 2 years.
2 years.
Okay. Um, the looking back at those 6 years, can you think of two or three things that you might change knowing what you know now? Just again, if we're giving insights to people that maybe are going to go down a similar journey, what have you done that, again, you had to get things done for, I'm guessing the CEO was not very helpful with the prescription refill, so your customer service scores dropped with that one.
No,
So,
thankfully my boss somehow intercepted that call and said, "I'll take that call now."
so what kind of things do you look back and say, oh, we wish we had done this differently?
You know, I don't know that we would have done a lot of things differently because I think with most organizations, they can relate in that we don't have the funding up front for a lot of this. We we aren't funded in a way where a for-profit call center model that has 50 agents in a nesting environment ready to go, that's not the way we operate. So I don't know that I could have done anything different other than it
Mhm.
would have been nice to have all the funding up front. Um, with thinking back to 2017, the several different consultants that came through and said, well, if you want to do this, you'll need a telephony system and we'll charge you $7 million. And then a year later, 2 years later, it's like, well, we got the telephony system. We did it on our own because we didn't have the $7 million to pay the consultants. And they come back and say, well, now that you have this, you need a CRM and we'll charge you $7 million to put it all together. Like, yeah, we don't have that either. So I don't know that I could have done it any differently. And really, it comes down to surrounding ourselves with the right team members that are willing to do things a bit archaic in order to get it done the right way to build the right foundation. I think
Sure.
I've certainly been blessed with amazing partners. I think of our director of clinical operations, Sharon Moodyman, who has stepped into every single role with us to build out all this work, but constantly says, okay, but how are we going to do this the right way for the next one? And just constantly evolving our thought.
Okay. We had a question come through in the Q&A. It's actually a question I want to talk about, so let's drop into that now. Um, the CRM system, I mean, you're using it for your contact center agents, your customer service reps, the non-clinical people that are taking those calls. Nurses.
Mm,
Nurses are an interesting question because if you go back in time, the Schmidt-Thompson protocols were really only available in contact center software, the CRM of those times. And so people had contact center software, the Schmidt-Thompson protocols were available there, the nurses were living in that.
mm,
And then through time, you've had the option of the nurses working more in the EMR through both Epic's triage module, through Clear
mm,
Triage providing that. Um, but then you have some people who are shifting back. So, for instance, one of Clear Triage's largest customers, the VA, has all of their nurses working in their CRM system.
mm.
And that is just so there are pluses and minuses. What are you guys looking at? Where do you think that nurses belong now, in the future? Where do you want your nurses taking calls between those two systems?
That's a great challenge, I think, for all of us to try to figure out together. But wholeheartedly, I believe that it's keeping our team members working to the top of their licensure and scope. So how do we tee up our nurses to have all of the relevant information rather than them having to dig through? And I think from a consumer perspective, I don't want to be asked the same questions that I may have already
Sure.
answered for somebody else, right? So I think from the CRM perspective, we actually just started having our nurses work within our CRM because we want them to have the real-time, most recent information about the patient, most relevant and recent information about the patient in front of them. However, we want them to be able to still have access to the EHR, full access, because this is not only just a time to provide acute services for that immediate triage need. This could be an opportunity to provide education. And if we have the time, I think that's one of the benefits to our nursing team, our RN triage team. It's also an education team. It's also
Sure.
able to dig into the chart and find out, well, what else can I talk to this patient about? Because again, we have them in front of us today. Um, so from that perspective, I see that our nurses will always live in both and maybe have one foot more into the source EHR system than into the CRM, but we haven't finished developing it yet. So I think it comes down to how much more can we enhance the capabilities of real-time information within the CRM that mirrors the EHR, the intuitiveness. I think that's where we ask our nurses to have not only access to different EHRs across CommonSpirit Health, but licensure in multiple states. So I believe our nurses are all licensed in at least 5 different states. And today, the Connection Center team, our team supports across 9 of the 24 states within 4 of the regions. So they're tasked with a lot. So how do we lean on OneConnect to help them reduce their training burden of having to know and understand so many different EHRs? I think that's another benefit to Clear Triage. That, to your point, while Epic has triage protocols built into their EMR now, that's wonderful if that's the only system you live in. But when you have different instances, I mean, for us, we have 4 different instances of Epic with I don't think I'm wrong if I say 10 different builds of those instances. Some may have the protocols built in, some may not. So how do you simplify
But
this
the
work? So I think that's where.
thinking about what you're describing there, it seems like, there's information, as you said, in the CRM, the most current information, because they've just been talking with people. You've got historical information and deep information in the EHR. You're going to have to move information for one system or the other if the nurse is there or the nurse is working both. Part of that seems like it depends on which system you can draw information out of. And if I understand right, you're using, is it MuleSoft to pull
Mhm.
information out of the EHR? And I would guess that that's a technology that really is growing. So you're probably able to pull quite a bit of things into the other place where the nurse is working. Is that correct?
Correct. I think that's where, again, I've learned so much in the last 2 years, um, more than I probably ever thought I would need to know about technical software. But MuleSoft for us is the middleware. So to to break it down as best I can, it's the middleware that translates the information from EHR to CRM. So for us, when we created OneConnection into Salesforce, OneConnect for us, it's then able to create the connection out to the different EHRs. So it's like a splitter. I'll call it a splitter. You've created the tether into the CRM. Now it's how many more points of contact can I make out to different source systems because I've already translated it into the language that needs to speak to the CRM. So rather than creating a one-for-one connection to every EHR, MuleSoft's allowed us to accelerate that. That once we built one connection for Epic, the next connection for Epic may not be as lengthy because we may be able to reuse a lot of those connections for the next one.
Right. But it's still going to take some customization for the next one because it's a different instance, a different build. And then I would also imagine that you have, even if someone's on the same build of Epic, different organizations use different fields differently. So you've got to pull those in because you want to have all the same information for the nurse in CRM.
Correct. This is where I wish it would be faster, but yes, it's taking us some time still to create all of these connections, but certainly faster than trying to move us in the direction of one single EHR. So while everything is happening in phases for us, and again, depending on the size of the organization, the amount of speed to action to speed to market is certainly going to be very different for all.
So, a number of the people that are listening or will be listening to this might be dealing with similar problems, but they might not be in an organization the size of Common Spirit. So, is it practical to build a CRM system for the kind of what you're talking about, to take some of that out, to make it easy for their agents, to maybe have the nurses living there? Is that practical for a smaller organization?
I think so. I think the way that we need to start looking at our our patients is now as consumers, right? So one thing that we've been able to do is streamline the work on the phone for our team members, but again, also for our consumers. If I'm able to navigate my work much quicker, not faster for the sake of hurry up and get to the next call, but truly to make it more efficient, and that's time saved for the person on the other end of the phone. The idea of the connection center is really one of our key metrics is first call resolution. So within one call, I'm not calling just to make an appointment. I'm probably calling for prescription requests, results. Where's my ultrasound? I had lab work done. I haven't heard anything. I forgot my password to the portal. All of those things. Can I take care of multiple issues or cases, in our case, cases within OneConnect to satisfy that consumer's needs? Um, I think, again, bringing everything to the front so that I don't have to dig into an EHR. EHRs are not as intuitive, and it's a medical record. Salesforce for us, a CRM for us, has been very customizable. It's certainly easier to customize OneConnect than it has been to submit tickets for EHR governance teams to review. And again, you're dealing with a much larger, broader audience than our use case. So to me, I think whether it's a smaller organization or a larger organization, it's all at scale. But I would certainly say that this has been a game changer for us.
I would imagine for a smaller organization, I'm not going to say this with absolute authority, but just throwing out there. So you and I have met a couple different places, but a couple times we've met at the healthcare call center times, contact center times conference. And at that conference, there are some different CRM systems geared towards healthcare. Genesis, Five9, they're different products. And I would guess that maybe some of those might be a little bit more tailored to, they may not have the initial um, burden, the initial jump you have to get into that you do with Salesforce. They may not be as customizable, but they may be a way for a organization of a different scale to get into the concept of having a CRM for their agents. Still, I know that those organizations, like Genesis, is working on pulling information out of EMRs, so it might be a way that some companies, some healthcare organizations can do what you've done, but maybe not at the scale.
I think, again, and yes, certainly I think I would be going out of my lane here as we get more technical. But to me, it's how many points of origin or source systems do you need to pull information from? And again, how customizable is the product? Certainly Epic has their own CRM. And as I saw, you know, demos of theirs or Salesforce, and thought, well, gosh, they look the same. To me, to the
Mhm.
operations guy, they look the same. You can customize them in the same way. I think it really comes down to, yeah, the technical debt and how much is it really going to take to connect all of these different systems? How well do they play with all of your different third-party softwares? And where are you trying to go? For us, again, we have our marketing teams that are using Salesforce. We have different orgs that use Salesforce. So I'm hoping that down the road for us, we can leverage that. However, we need to talk about generative voice AI. So whose um, telephony platform or whose AI software is going to play well with a Genesis or Five9, a Salesforce? Those might be the other considerations of what
Sure.
technical debt do you already have and how do we leverage it before we scrap it.
So you've brought something that we have had kind of as a theme through some of these conversations. So I will toss it back to you. How are you seeing generative AI changing your plans, changing what you want to do? What do you see as kind of the first things that it might be able to influence your contact center, and what do you think it might do a little bit further out?
Well, I think for one, it has to work, right? I think we still have, and I'm sure there's other organizations, maybe even more rural organizations that struggle with this as well. Patients don't want to talk to a call center. They want to talk to their doctor. They want to talk to the person in the office. And while for us, that's certainly not as feasible, it's not as efficient for us as a larger organization. But if we're going to go down the path of generative voice AI, it better sound like a real person, because I think what we don't want to do is go down the path of trying to solve the low hanging fruit uh, challenges, issues, reasons for call, and only to go to back to a customer service representative, a patient service representative. So we're starting with the simpler tasks, the tasks that such as, and again, scheduling is by no means simple because there's a lot of work behind the scenes to make sure that we code and configure the right way to get to the source systems. But again, we're hoping to leverage the clinical scripting that we've already built out. We're hoping to leverage the existing connections that we've already made through MuleSoft, through Salesforce into our EHRs. But bottom line, it's how do we give people more time? Because how great would it be if I could say, I'm okay with cycle time being 15 minutes for every call because the simpler calls are being handled by a bot. And we can give time back to our staff to create those human connections with our patients so that when I come into the office, I'm saying, hey, where is Dave? I talked to Dave for 15 minutes. He helped me navigate this and say, oh, he works in our connection center, right? So to
Sure,
me, it's how do we leverage it to really help build human connection for the things that really matter.
that makes sense. We're getting close to the end of our time here, and so a last piece I wanted to bring up. I've mentioned the healthcare contact center times,
Mhm.
and that is where we met. And I
Yeah.
will see you again in a month and a half there.
Yes.
Um, you're the co-chair of the conference this year. Kind of what is your interest there? Why you've got a lot going on. What do you see in that conference that said, I want to support and make this a better conference? And what do you think it could bring to people who are listening here?
Sure. I think this will be my third time attending this conference, and I jumped into the opportunity to help guide people like me that I think of the conference as a place where I've certainly gained a lot of information from a call center perspective, from a contact center perspective. But more than that, how do we give leaders that come to this conference a visual of how they are not just an administrative burden on a P&L, but really a revenue generating part of the team that without the contact center, there is no front line to bring in the patient. Without a functioning front door, whether it be virtual or through the phone, how do we make sure that we're guiding patients and consumers to the right level of care? So bringing together so many different organizations, but then again, I think to your point, that's where we met, and I think we've just enhanced our delivery back to our consumers, and our consumers being our physicians, our practice administrators, our patients, our frontline team members through building connection with, teams such as yourself that have helped us not just by providing a service. There's so many different vendors out there that provide services, but I'm going to say thought partnership. That, one thing, Dave, I'll, say thank you to you for always being a thought partner for us in whether we were truly rolling out a contract even further, or we were just talking about, okay, what would the future look like if we did ABC? So I think those are the benefits that people will get from attending that conference. So hope to see a lot of folks at the health healthcare contact center times conference this year. I think June or first week of June, June
First
4th.
week of June in Atlanta.
Yep,
Yes.
in Atlanta.
Well, Cecilio, thank you so much for taking time to
Appreciate
talk
you.
with me today. I really do appreciate it. And looking forward to seeing you there. And
Sounds
thank you
great.
everyone else for joining. Um, we do have our next 10 for 10 webinar is in May. It is during National Nurses Week. So in honor of National Nurses Week, we're going to be talking with all the different nurses that are part of Schmidt-Thompson clinical content. So the nurses that create the nurse telephone triage protocols that many of you use, a chance to get to know them and what their role is in the maintenance and the creation and maintenance of those protocols. So please, if you're not already signed up for that, go ahead and do so. Any additional questions, and we're just about to close this webinar, so feel free to email questions for Cecilio or anything about the conversation today. You can email those to support@cleartriage.com and we'll get them to Cecilio. And thanks again. Have a great day.
Thank you, Dave.